Good morning. This is Dr. McDaniel at GYN Corner, and I'm an obstetrician gynecologist in New York City, Midtown Manhattan. I'm bringing all things health related to women on a daily basis here at the Facebook live stream. I'm also on YouTube, and I have the presentations coming in daily on YouTube. That's also GYN Corner. We're also on a podcast called Surprise, GYN Corner. The podcast is presenting the talks 3 times a week, and we're available on 8 platforms, the most popular being Anchor, Spotify, Apple iTunes, Google Play. So please check out the podcast, the YouTube, and join us on the Facebook live streams. Please subscribe and follow if you'd like to get a heads up and information whenever I present a new talk, discussion, presentation for information on women's health. As the title indicated, today I'll be speaking on the treatment of ectopic pregnancies. This is part 2. Yesterday, if you go to yesterday's presentation, I spoke about the surgical treatment of ectopic pregnancies, and that's a classic standard, what we call the gold standard form of treatment is surgical. Today I'll be speaking on medical treatment of ectopic pregnancy. And as a brief recap, an ectopic pregnancy is a pregnancy that occurs outside of its normal location, which is the uterus. And that's because everyone who gets pregnant in the fallopian tubes. That fertilized egg flows down the fallopian tubes into the uterus and latches onto the uterine wall around 4 to 5 days after fertilization. If there's a problem with the fertilized egg getting into the uterus, it doesn't get all the way into the uterus, it gets arrested in the tubes, or it falls out of the tubes, or it gets into the uterus and almost falls completely out of the uterus, it latches onto the cervix. Those are all ectopic pregnancies because they're in an abnormal location. So we can have cervical pregnancies, tubal pregnancies, abdominal pregnancies, pelvic pregnancies, ovarian pregnancies, hepatic pregnancies, the list goes on and on. So the surgical treatment is what we used to always perform, but around the early to mid 80s, a medical form of treatment for early ectopic pregnancies became available. What do they say? How do they say it? They say it came on the horizon. It came on the horizon. It became available, and that medical treatment was with a chemotherapeutic medication called methotrexate. Now, traditionally, we used to use methotrexate for abnormal pregnancies that cause tumors or cancers of the immature placenta. Those are called hydatidiform pregnancies, molar pregnancies, choriocarcinoma. So we had a long history of using methotrexate to kill off those precancerous and cancerous pregnancies for years. Methotrexate is a chemotherapeutic drug which kills or destroys the ability of rapidly growing cells to multiply and to grow. So they kill off rapidly growing cells by interfering with the protein, the primary building blocks, amino acids. So it became available through research in the early 80s that we could also use very low single and occasionally double doses of methotrexate to treat very early ectopic pregnancies, because those two, similar to tumors, similar to cancers, those are rapidly growing cells. So now, as I stated last week in the presentation, the most important aspect of treating an ectopic pregnancy is diagnosing it. So when someone becomes pregnant, they do a home pregnancy test, they miss their cycle. As soon as they find out that test is positive and that they're pregnant, they should come into the gynecologist's office for blood work. That blood work always includes a pregnancy hormone level, and that's called a HCG, or human chorionic gonadotropin level. If that level is adequately high enough for how far along that person is supposed to be during the pregnancy, we will schedule an ultrasound when she should be 6.5 weeks of pregnancy. If it's not normal or it doesn't look like it's appropriate for how far along she should be, 4.5, 5 weeks, 5.5 weeks, then we'll ask her to return in 2 to 3 days to repeat that number. If the number is not appropriately rising, or if that pregnancy hormone number is 1200 MIUs or higher and we see nothing on the ultrasound or the sonogram, that's consistent with an ectopic or pregnancy. We may or may not actually see where that pregnancy is located in the pelvis or in the abdomen, but if it's not in the uterus, there's not a pregnant uterus, the number is above 1200, then that's an indication that, I guess that's confirmatory. It confirms that she has an ectopic pregnancy and she should be treated. If we see that ectopic pregnancy on the ultrasound and there is not a beating heart, the pregnancy hormone number is less than 5,000, then that's always indicative that a medical treatment will be predominantly the best and safest route. Now, a relative contraindication is if we do see a fetal heartbeat, and if the gestational sac is 3 centimeters or larger and the pregnancy hormone is above 5,000, those are all indicative that a medical treatment will probably not work, and then the surgical treatment will be the best route. If the medical treatment is deemed appropriate, she's given methotrexate, and it's usually 50 milligrams per meter squared of her BMI. On average, for an average woman, that ends up being around 100 milligrams of methotrexate. Occasionally, if she's very heavy, it might be 125 to 150 milligrams of methotrexate, and it's an intramuscular, so it's a shot in the arm or shot in the hip. We check her hormone numbers of the pregnancy number, the HCG, the day of, and then we also check liver function tests because it's liver metabolized. So if someone has compromised liver, or they have fatty liver, or they have a hepatitis, it may not be metabolized appropriately. It may cause damage. So we always get the liver function, electrolytes, and that pregnancy hormone number the day of. She's given the methotrexate, and then she's asked to return in 3 days. Now, most women will have increased cramping, a little increased bleeding. I tell them that's normal. That pregnancy hormone number may actually rise a little bit on the 3 days when she comes back to check it, but if she's not doubled over in pain, she's not abnormally heavily bleeding, then it's considered within normal limits. And when she comes back in 3 days, we'll check the number to see if it's only a little bit risen or if it's a lot bit risen. If it's only a little bit risen, then she doesn't need anything additional done. We'll have her come back 7 days after that initial shot and check the numbers. The numbers should be at least 15% lower for that HCG. If the numbers on day 3 are quite a bit higher, then that warrants another ultrasound or sonogram to confirm that the status is still reasonable to continue medical treatment. If it's still reasonable to continue medical treatment, then same story. That blood test for the HCG and the liver function is repeated 7 days after the initial shot. If that number is at least 15%, I like to see 25% on average lower, then we'll just keep monitoring her twice a week and then once a week until the number is completely down to negative. If the number is not at least 15% lower 7 days after that initial treatment, or for me, if it's not 20 to 25% lower, the patient will get a second shot. And I always tell people when I give them the first shot what the plan is, that we'll do a second one on day 7 if it's not a good chunk lower. If she gets the second shot on day 7, then I'll have her come back in another 3 days, and if it's dropped fairly precipitously or a good chunk lower, then we'll just monitor once a week because we know it's kicked in, and we won't monitor once a week and then once every 2 weeks if it's dropping by leaps and bounds until the pregnancy number is 0. If it has not dropped by a lot, but it does continue to drop slowly but surely, then I'll just check her twice a week a few times to make sure that it's really coming down and it's not just fluctuating. Some women will have cramps throughout the entire time, light bleeding. As long as she's not doubled over in pain, the bleeding's not crazy, she doesn't need any additional sonos, there doesn't need to be any kind of interference. If she does feel like the pain's getting worse, then she should have another sonogram just to make sure that even though the number's dropping, the pregnancy didn't actually start to rupture through whatever organ it happens to be in, and that there isn't a lot of blood in the pelvis, because a lot of blood in the pelvis is going to be a big source or a primary reason for worsening pain. Once that pregnancy number is down to 0, the bleeding should have either stopped if it already started, or sometimes it doesn't start till it's really, really low. I tell the patients that the bleeding should be like a menstrual level bleeding, should be like a heavy period, and it should peter out within 7 to 10 days. If it hasn't petered out within 7 to 10 days, then another sonogram is warranted just to make sure there's nothing unusual going on inside the uterus, that everything's appropriate. So that's the medical management or the medical treatment of ectopic pregnancies. It's with methotrexate, a chemotherapeutic drug that we've used for many, many years, good 40, 50 years, for the management of abnormal pregnancies, and now for the management of ectopic pregnancies for the last 40, actually I guess it's 60 years now for abnormal, for precancerous, cancerous pregnancies, and 40 years for ectopic pregnancies now. I've been using it for almost 30 years now for ectopic pregnancies and abnormal precancerous, cancerous pregnancies. So I hope that's been helpful information. Please check out the presentations from last week where I went into more depth on ectopic pregnancies, different types, diagnosis, management, signs and symptoms, and then this week on the surgical and now the medical treatment or management of ectopic pregnancies. If you have any questions or if you'd like to make comments, please post them here on Facebook, on YouTube, and on the podcast GYN Corner. I'll be back tomorrow with another presentation. Please follow if you'd like a heads up on when the presentations are coming live and what the topics will be. Thanks again. Have a great rest of your Tuesday. Be back tomorrow. Bye.